So to continue, best practices don't always benefit the healthcare consumers. If you think about quality bonus payments pay for performance are supposed to be built on improving best practices. But I'm going to give you an example of a best practice that doesn't always work for people. Unicompartmental knee arthroplasty, uni-knees, is a pay-for-performance initiative preferred surgery over total knee arthroplasty. There's a lot of reasons for it, and they're good reasons. Uni-knee surgery preserves the existing anatomy. It significantly decreases the need for postoperative analgesia. It shortens, or in some cases completely eliminates, physical therapy needs. It costs 20 to 80% less than total knee surgery. And when I did a study on Google Scholar, I counted 5,000 plus articles that tout the overall improvements uni-knee surgery brings to patients and to surgeons. So it's a good plan, so it seems. Further reading led me to a bunch of reports that I found. One example, Lito and colleagues found that the revision rates on uni-knees are considerably higher than those on total knee surgery. Some of these studies that I looked at showed revision rates of 35 to 85% of patients who got a uni-knee had to go back and get a total knee later. Although the initial surgery had considerable benefits, many of which might be worth the bonus payment, the revision surgeries include considerably higher costs. These costs include human costs, pain, longer duration of physical therapy, marked increase in financial costs that might have been avoided had the surgeon done a total knee the first time. And this isn't to say that every partial or uni-knee ought to be a total knee. It's just that the surgeons have been incentivized to do a total knee or a partial knee, when in fact a total knee might be appropriate. And this incentive could be, I'm not saying it is, could be driving surgeons to do a uni-knee in place of a total knee when it's not appropriate. The surgeon actually benefits from this, though. The insurer pays the surgeon twice. Once for the surgery that was conducted with the uni-knee, which got a pay-for-performance bonus, and a second time for a total knee. Not saying that this is always the case, but it's a pretty distinctive case. Many organizational pay-for-performance projects use a combination of claims data, which includes HEDIS data, TJC core measures, and all of these things that quantify quality. One paper I read, Mahorda, Bodenheimer, and Dudley, suggests that many direct care providers find these measures of quality completely inadequate. Baker and Carter said that MCO measures of quality in terms of process improvements leads to outcomes such as improvements in healthcare technology infrastructure that might not really benefit the patient directly. Some providers identify quality improvements as initiatives directed at specific payments, like the aforementioned hemoglobin A1C in diabetic patients. But it's really kind of challenging for researchers to address these models and the disparities that these models cause. So you have to be really careful in assessing whether it's the right pay-for-performance model and whether that pay-for-performance model is appropriate to the patient's needs. So to improve the body of evidence on pay-for-performance, CMS has been conducting since 2003-4, I believe, several demonstration projects to promote quality physician and hospital practice. Positive preliminary reports from these demonstrations, along with other available information, led Congress to pass a law called the Tax Relief and Healthcare Act of 2006. This law requires the creation of a physician quality reporting system that provides a means for reporting and monitoring physician quality to use as a basis for pay-for-performance downstream. It's being built, it hasn't been really used yet. Physicians that report regular and satisfactory quality information under this program earn incentives equal to 1% above ordinary Medicare Part B. That accounts for a relatively small proportion of physicians. They're going to expand this considerably. Lindenauer et al. Conducted a case control study looking at pay-for-performance measures on 10 quality measures collected on 613 hospitals. It was a 1-to-2 case control study with 207 hospitals that were part of the CMS demonstration project and 406 non-participating controls. What they found suggests that the demonstration hospitals achieved significantly higher quality on 7 out of the 10 individual quality indicators, which include acute MI, heart failure, and pneumonia. The statistically significant improvements accounted for only 2.6 to 4.1% overall improvement. Now, these improvements are small. They really do represent an improvement that's worthy of further investigation, and it could lead to additional significant and clinically significant measures later, improvements in measures later. After reviewing this paper, though, I really want you to ask yourself, did the improvements actually represent higher quality care, or did they just represent higher quality reporting of care? Further, the health reform law funds CMS to conduct research to determine the best methods for extending the existing pay-for-performance methodology to Medicare Advantage insurers. The hope is to produce faster and larger gains in annual quality improvement scores that are awarded under the new five-star quality rating system. Now, considering all this, there's a great deal of concern regarding the effectiveness and rigor associated with applying pay-for-performance to the five-star quality rating system on these Medicare Advantage insurers, because a lot of them have different levels of control. HMOs control their physicians much better than preferred provider organizations. And also, Medicare Advantage organizations that are smaller might have more control than those that are larger, or vice versa. Now, the historical development strategy gives some basis for understanding the best practices in Medicare Advantage and pay-for-performance. I'm not going to go through the timeline, but I will say that it starts right around 2005 and ends in January of this year. Now, Rosenthal and Dudley, as I mentioned earlier, they did a review of pay-for-performance, and they looked at 5 key dimensions, including individual versus group incentives, paying the right amount, selecting high-impact performance measures, making payment reward all high-quality care, and prioritizing quality improvement for underserved populations. Now, this paper goes on into valuable detail. I highly recommend reading it on each element, but I'm just going to briefly give a quick overview of the salient points. The individual versus group incentives. This refers to the downstream target of the incentives. In this case, the providers individually or the systems for whom they provide care. Targeting individuals has the very direct advantage of incentivizing providers for something they can actually control, the care they give. Alternatively, these same providers could be giving incredibly good care under incredibly poor circumstances. In such a case, maybe these providers would benefit from actually improving the systematic flaws, so providing group-level incentives. In this case, that high tide might lift all boats. Additionally, paying the right amount. This refers to appropriately targeting and valuing the incentives. Like I said earlier, this same group found that a $2 incentive had an incredible influence on quality outcomes, while a $10,000 incentive had no measurable effect. Take-home lesson on this is that the incentive should follow the need. Think about this. Many of us, me included, will buy our 15 coffees at Starbucks so that we can get our 16th coffee free, that Sweet 15 program that they've got. These are $4 coffees. 15 of them cost me $60, for which I'll get a free $4 coffee. Frankly, that's less than a 7% discount, but I still stand in line like an idiot to do it. The next is selecting high-impact performance measures. This suggests that providers speak up on what and how the project measures performance. The provider should be involved in selecting the performance measures. Making payment reward all high-quality care suggests that the current programs incur an unintended competition consequence that leads providers to either inflate their outcomes or compete for easy patients. The recommendation from Rosenthal and Dudley is that they should focus on high-value care, such as the aforementioned hemoglobin A1C. This would incentivize providers of all diabetes care to improve the care quality. I'm going to run out of time. Finally, let me just say, prioritizing quality improvement for underserved patients. Very similar, provide the best care for the underserved by giving them financial incentive for translators and transportation services. I'm not going to go into another short lecture on this, but please review the points that came across from Lynn et al. As well. Thank you.